Good afternoon, everyone. Yeah, I would like to start by thanking Professor Abdelwahab for giving me the opportunity to share our 36th scientific year conference and for choosing the theme of our conference to be red flags in pediatric practice, which is very important, practical, and interesting. It's been a long day. I would like to be as short and interesting as possible. I choose the topic inherited bleeding disorders because we're still rare. Yes, in the population of ours, there is nothing there. We're in the population of 120 or more than 120 million people. The thing is with inherited bleeding disorder, though the mortality and morbidity is quite high, yet timely proper management can save the life. The thing is, I'm going to tackle this topic as a general pediatrician, highlighting some important points. If you see here, these are 4 case scenarios that I think each and every one of us has encountered in their clinical practice, whether it be in neonatology or general pediatrics. So, a 4-year-old boy, by the way, all these are male patients. A 4-year-old boy presented with recurrent nosebleeds or epistaxis all the way through, but it was mostly during the summer. Patient was treated conservatively and also was communicated to 5 capillaries of definitely fertility. The second scenario is the baby boy delivered by mobile vaginal delivery who started to have umbilical bleeding on day 5, as well as a multi-failed hematoma that required replacement with FFPs or fresh frozen plasma. And then it was discharged home, again with nothing further to be done. Third case is a 9-month-old boy who developed spontaneous, according to his mother, right-hand convulsions, theater, power, vomiting, and high-pitched shock. The CT scan was done and showed subdural collection. Hematoma was evacuated after the baby received his plasma, and his recovery was uneventful. Then there's this 12-year-old young girl who presented by heavy menstrual bleeding at menarche that led to severe pallor, renal heart failure, admission to ICU, and she received back to RCs. She had a family history of a similarly affected family member. Okay, so after these scenarios, they are faced with very important 3 questions. Why is this happening? What are the red flags to diagnose an inherited bleeding disorder? How should we proceed further? So why is this happening? Because of an underlying inherited bleeding disorder. According to the World Federation of Hemophilia Global Survey 2022, World Federation of Hemophilia is an NGO that its goal is all treatment for all. It's based in Canada. They do a worldwide survey. The last one included our Egyptian cohort, and it included 427,000 patients with inherited bleeding disorders. In very simple terms, inherited bleeding disorder includes coagulation factor deficiency, starting from the very common von Willebrand disease up to the less common or less frequent hemophilia A or B, comprising 1 to 10 up to 30 cells. And then comes the rare coagulation disorder, with a prevalence of 1 per 500,000 up to 1 per 2 million. Then come the platelet function disorders. As you see here, maybe sorry this is just wrong, but regarding our cohort in Egypt, all the inherited bleeding disorder comprise about 10,000, which is quite low. So there's lack of awareness. So one of the goals of our lecture today is to increase awareness. Okay, red flags. When to think an inherited bleeding disorder? First of all, we need to know what is the difference between a significant and insignificant bleed. The high frequency of bleeding symptoms in the normal population and the subjective appraisal of symptoms by patients or parents makes indicating the pathological nature of bleeding difficult. So it's called for what? A standardized bleeding assessment tool. And semi-quantitative bleeding scores, which is now the gold standard to diagnose any bleeding disorder. It helps discriminate the normal from the abnormal bleeding. It's called ISTH-PAT. ISTH-PAT refers to the International Society of Thrombosis and Hemostasis, which is the most important and the most elite society for inherited bleeding disorders. And this is the diagnostic tool used in subjects with suspected inherited bleeding disorders. Now, second red flag, we're going to go through the definitions and always remember the number 10. 10 is very important. When to consider an epistaxis or allegedly significant, more than 10 minutes, intervening or distressing of daily or social activities with a frequency of more than 5 episodes per year. Now, the other thing you can go and notice in many patients is the cutaneous bleeds, or the bruises, or the ecchymosis. More than 5 bruises, more than 1 centimeter exposed, there is significant. Regarding oral bleeds, again, our golden rule of 10. Gum bleeding is considered significant when it causes blood sputum. And by the way, I diagnosed a patient with factor 7 deficiency only when he presented with initially at the neonatal period with a blood sputum. Again, tooth extraction, tooth eruption with prolonged bleeding more than 10 minutes. Now we come to the more severe sites of bleeds and significant ones, the genital urinary as well as the GIT. Whether hematasis, malignant, bleeding pruritic, or hematuria, they are considered significant if there is no specific disease to explain them. And then there's the atypical sites, the muscle hematomas and the hemophysis. We should never forget the hemorrhagia. Hemorrhagia is significant when it interferes with the person's quality of life and when it lasts more than 7 days with blood clotting. Regarding the mostly central nervous system bleeding, please, any subdural or intracranial hemorrhage requiring diagnostic or preventive intervention, whether spontaneous or post-traumatic, please investigate for underlying emergent bleeding disorders. And also regarding the surgical bleeds and the minor wound bleeding, if we have, as you see here, prolonged bleeding, we need to investigate. The other important red flag is the sex of the baby, but that's only important in accident recessive disorder as hemophilia A and B. For the other rare idiopathies and lumbar band, brain function, all these are autosomal. Consanguinity and family history, very, very important, and especially marriages into close communities. Now, this takes us to the third question. How should we proceed? We should take detailed history taking over bleeding symptoms, as we saw previously, and very importantly ask about response to hemostatic challenges, whether circumcision, dental procedures, consultation, very, very important. And by the way, significant bleeding can take place after these challenging situations and the patient will get afterwards undiagnosed. Also, we have to exclude underlying medical conditions or intaking medications, and again, I'm highlighting family history. Complete physical examination should include everywhere. Never forget muscles, never forget joints, never forget the internal oral cavity. Okay, second thing is we are going to proceed to laboratory investigations. Complete blood scan, please always ask for a blood smear to look at the platelet morphology. And afterwards we can do a bleed time, it can be significant depending on how the test is done and who is doing it. And then we'll do the platelet functions if and when indicated. Then we'll proceed to the coagulation profile. That will include both thrombin time, partial thromboplastin time, thrombin time highlighted in red, never forget to diagnose hereditary disorders, which comprise actually the rare coagulation disorders in Egypt. It's very important, and these patients are liable to develop bleeding and thrombosis. As you can see here, if there is isolated prolongation of PT, then this is extrinsic or probably factor 7 deficiency. If there is isolated prolongation of the partial thromboplastin time, then this can be due to deficiency of factor 8 and 9 and 11, and we have factor 11 deficiency in Egypt, and afterwards we can proceed with specific factor essays. Don't forget the defects, but they have to be confirmed with functions. And this is going more explicitly on the laboratory diagnosis. And here, don't forget when you have prolonged PT and PTT to think about the common pathway. And also, don't forget if you have a normal coagulation profile, to not say, this patient is okay, this patient can have factor 15 deficiency, especially in a community like others. So, treatment in a nutshell, because this is the second phase, it's either on-demand or prophylaxis, and it will include the replacement, adjunctive, as well as correct RBVs. And never forget the complications of disease and treatments. Take home messages. Common is common, but rare is also present. So you have to think rare living disorders in order to diagnose them, and they can present at any age. Can I have just 1 second? If possible, if not, it's okay. Thank you. Just 1 second. Yes, okay. The red flags for heavy bleeding disorder include positive consanguinity and family history, significant bleeding by the STH18 or 4, if bleeding from a common site is usually severe, recurrent, and can be spontaneous, and if from uncommon sites, will it can be muscles, the joints, and umbilicus. And thank you. And this is here how our the patient when early diagnosed and properly managed. This has factor 7 deficiency, unfortunately. This one has factor 7 deficiency with mental cerebellity, and this is another patient with hemophilia who had cerebral bleeds but properly managed, and that's why it's become a young man. And special thank you to our patients and their families, all our hematology department, chair nurses, and our hematology team. Thank you very much.
Thank you very much, Dr. Magy, for your very elegant presentation. But I want to stress one point which is really out of my practice. I noticed that the family history is very important. When you ask about the family history, you have to stress. When you are young, you have some tuberculosis, the mother, you have neuralgia. This is very important. And many of the congenital and hereditary blood disorders and bleeding comes from the family history, the positive family history, of course, together with the lab examination. Thank you. Is there any question for Dr. Magy?
الابلكيشن on BD تعرف تشتغل مع الانتخابات السنوية.
سوري.
بقول لازم واحد فيهم يسيب الثاني، تعرفين زي دايبيتس ميليتس ودبل مايك. دبل مايك خلاص يعني هو دايبيتس ميليتس يعني لازم
I like